several months ago, we started talking about CMS and the interpretive guidance that we had for long-term care. And so now we have new updated CMS interpretive guidance focused on acute care. So as we spend our time working across the healthcare spectrum, I'm very appreciative of Dr. Hudson Garrett to give us this updated information so that we continue to work across facilities and across organizations, and then help us understand the bigger picture with some of these regulatory and compliance approaches. So Dr. Garrett, thank you for leading today's grand rounds.
Awesome. Thank you very much. And thank you to you and Dr. Ramirez for the invitation. I apologize that it looks like I'm in a bunker, but I'm actually in an undisclosed location in the Atlanta airport right now. So appreciate the patience, but also want to extend my sincere sympathies for those of you that are going through the floods right now, and let you know that my sincere thoughts and prayers for your families, friends, and also colleagues as well. So as Ruth mentioned, we want to spend some time talking about the new CMS interpretive guidance for really acute care and talk about some of the things that have come from this. I'm going to sort of break it down into two various pieces. You're going to notice one is really the topic, right? And what is specifically changed. And then the second area is what are the surveyors going to be looking for in terms of measuring us for success. What you'll notice pretty quickly is, in typical CMS style, that there are recommendations that many of which we're probably already doing, some of which we're probably already exceeding, and then there may be some new ones, which is what we're going to focus on today, that give some guidance, but they don't actually give the resources. And so particularly from a staffing standpoint, how do we make sure that something actually gets accomplished? And then how do we measure towards success are sort of the three elements that I want you to keep in the back of your mind as we sort of talk about these core areas. What I did is I went through the entire 22-page document and took the areas that had been updated. I'll also share the full PDF of the interpretive guidance in case you've not had a chance to read that, so that you've got that as well. We've got a few folks that have not muted their lines, so if you wouldn't mind muting, that would be great. The first content area that they focused on was really the infection prevention program and the antibiotic stewardship program. So we all have these programs in place, but really what they're looking for is this going to be aligned with the services that you offer, and is it effectively resourced? And so part of this is, do we have the right people involved? Do we have the right objectives for the program? How are we measuring for success? And there's also a lot of discussion in the new interpretive guidance about the engagement of the governing body. So for most of us in the hospital space, that's going to be our board of directors, right? Our board of directors, our executive suite, but really at the end of the day, the governing body is going to be the board of directors. They also want to see that the infection prevention program is very closely integrating the antibiotic stewardship program. And this has to be something that's going to be done hospital-wide, but also from a survey perspective, if we've got outpatient facilities, they want to make sure that these efforts are being universally applied there as well. And lastly, one of the new things that they directly called out was really sort of this method in order to deal with visitors, as well as staff, patients, and everybody together. And so part of this has been a focus on, historically, we've really sort of boxed in all of our efforts with patients. And then we said, well, there's other people that come in, and we learned this with COVID. We've got visitors and people of the like that, well, we can't have them come in because it was too unsafe. And so really now there's this challenge to say our program has to encompass all of the different people that come in and out of our buildings. This also would include people like contractors as well that might come in and out from that perspective. So just something to sort of reflect on. In terms of the survey procedures, they want to make sure that you're using some type of nationally recognized infection prevention and control standards of practice. So most notably, we're all going to go to the CDC. And so that is always going to be the safest bet where there is practice guidance that exists for the particular area that CDC has. Let's go there first. Now, there's also going to be elements of performance that we might need to go to specific areas. For example, if I'm looking for something that's very directly targeted to the perioperative environment, it might make sense for me to look at the SSI guidelines from CDC, but then to go to ARN for a perioperative nursing perspective, because that's really where the bulk of those guidelines may be. The other piece too is that they want to evaluate how effectively managed our written standards, policies, and procedures are. right? And is this directly tied back into our quality assurance as well as our performance improvement process? So not only do we have to have the standard, but we've also got to make sure that we're measuring for performance and we're sharing that feedback. At the very end of the program today, I'll sort of give a quick update on that piece too, where they're talking about competency-driven training. And this is something that I've been preaching for years. Ruth knows this for sure. We've talked about this in many lectures, that we don't want to have just training. We need to have something that's role specific and competency driven so that we're not spinning our wheels like hamsters and not getting a different outcome, right? That whole definition of insanity. So one of the other things they're looking for is, do we have some type of active process that's going to be hospital-wide? Right now, this doesn't mean that we have to go surveil for every single type of infection everywhere, but we need to be set up if we need to sort of flip that switch on for a particular need or flip it back off. Maybe we have an outbreak of a particular pathogen as an example, and we need to turn on surveillance whole house for a period of time just based on the incubation and the risk of spread. Do we have the capabilities of doing that? What about from an antibiotic stewardship standpoint? Are we monitoring the prescribing behaviors? Are we looking for the formularies? Do we have a good understanding of our antibiogram? And are we feeding that information back to the prescribers from our quality improvement and our performance elements, right? So that we can really drive change based on individualized data as much as possible. If we can get that back to the prescribers, it's going to make it even better. But again, they're looking at, are we doing this based on the national benchmarks that we have? Now, certainly from a data perspective, NHSN is going to be helpful for us, but we certainly also want to look at the evidence-based standards from a clinical perspective as well. So here's one that I actually was pretty excited about, which is really the involvement of the governing board. Now, the governing board, right, is the one that has, at the end of the day, the total responsibility for ensuring the resourcing of the program. They also should be responsible for appointing that individual. Now, let's say that you have somebody who says, well, I'll be the infection preventionist. Well, great that they raised their hand and said yes, but maybe that person has zero training in infection prevention. Maybe they have zero certifications in that area. Maybe they don't have any clinical background. Maybe it was somebody who has been a microbiologist for 30 years, but has never really worked outside of the lab. Are these the ideal people for that type of role, especially in a leadership capacity? Probably not. The same could be true for somebody who's worked in nursing forever, but doesn't have some of the other skill sets that we need to be a well-rounded infection preventionist. And so part of this is really developing leadership tracks so that the governing board is appointing individuals that have the necessary and requisite experience, but they have the desire to continue to do this. Part of this too is when you go back to leadership and say, I need to continue my competency so that we can meet these requirements, that's going to be an element of performance that hopefully will drive continuing education, right? Not just the maintenance of certification, but really looking at other things that we can do. Can we go to conferences? Are there things that we can do from a performance development standpoint? Are there leadership tracks that we need to sort of hone in on, maybe with better communication? Or how do we prepare for a board meeting as an example? Right. And so the hospital itself is designed, right, to run a clinical operation. But with that comes financial and operational obligations. And so the leadership team, with the governing board's involvement, has to select somebody that's going to not only head up the infection prevention program, but also head up the antibiotic stewardship program. And this has to be directly tied back into the organization's culture of safety. That is an important element, especially when we look at what are we doing to ensure that this is a culture change, not a process only change, right? When we get down to the levels of culture change, we have more success and it's more sustained. So how are these individuals, as infection prevention is designated, right? It's really going to be a combination, and they specifically call this out in the guidance. So let's take somebody, for example, who might work in long-term care, or somebody who may work in an ambulatory surgery or a dental practice. You're not necessarily going to find somebody that is always a nurse. You're not going to necessarily find somebody who's always CIC certified, but you're certainly going to find people that have different backgrounds, different skill sets, different exposure levels, and maybe they've gone to different conferences and professional development training that could bring to the table the relevant knowledge and expertise to do the role. And so it's really a nice combination of all of these. Do they have some professional education? Do they have some type of continuing education? Do they have experience in this particular area? And might they be certified in that area? Now, keep in mind that for the hospital space, right, we know that we have primarily one certification. In the long-term care space, there's now 2 certifications. In the dental space, there's a certification for that. And also in ambulatory surgery, there's a certification for that. So each of these certifications is designed to be specific to that clinical care environment. But for purposes of our context today, we're really talking about hospitals. So the things that were really called out in this interpretive guidance as the new categories that they've drilled down a little bit deeper into was, do we have the policy and procedures in order to execute our goals, right? And our goals are going to be based on the services that we provide, the clientele that we serve, the community that we're responsible to, but also really thinking about what are our capabilities. The second area that we've sort of touched on a little bit so far is, do we have a good, thorough antibiotic stewardship program, not just in policy, but truly in practice? Is it something that we're measuring and we're able to look at the sort of trends and say, yes, we're moving in the right direction, or no, we're not, and here's what we're doing about it? The third bucket is probably by far the most important. Do we have the right leadership? Do we have leadership that are engaged in the process, that are saying, what do you need in order to be successful? Do we have areas that are going to help us be moving obstacles out of the way? Maybe it's individuals in the C-suite. And then lastly is our process that we're doing completely integrated? Is it going to be effective because we're engaging quality improvement, performance improvement, patient safety, risk management, the medical staff services, the frontline clinicians, right? So that we can actually get that needle moving towards the right direction. So one of the most important ones is always staffing. And, just in typical CMS style, they don't say how many members of the staff you need in order to execute the program. What they do say is that you need enough staff in order to sufficiently execute the program. So that is really a little bit of a miss, I think, and I think we would all agree with this, that we continue to see sort of this gap between what's expected versus what we're actually able to resource. And without a specific staffing ratio, it's hard for leadership to have their hand forced in order to recruit. But that doesn't mean we can't be successful. We continue to see growth in infection prevention and control programs and institutions where they're making the business case. They're delivering the results. They're sharing the data. They're really, doing targeted competency-driven education. But you have to have a good model. You also need to think about the diversity of your team. It's not the day of where everybody was a nurse or everybody was an MPH or everybody was a med tech. We have such diversity in the people that we can hire now. Some folks will come with many years of clinical experience. Some will come with none, right? It really doesn't matter, but we have to have the right requisite group of people on our team so that we can accomplish the goal. Now, if I worked in a critical access hospital, right, where I've got very, very limited resources, I might want somebody with a high degree of clinical acumen to be in that role if it's one person. If long-term care, maybe the same thing. But in acute care, we have a lot more flexibility because we take care of a wide variety of patients. We have different responsibilities. So we may need somebody with more micro expertise, somebody with more of that epidemiology expertise, and somebody with more of a nursing expertise. And all of those people together can form a really unique, high-powered team. But again, we're not going to be able to dictate to our leadership team what the requirements are for staffing. And so we want to look at the types of patients that we serve, the sort of services that we offer, the throughputs that we have, whether it's inpatient versus outpatient, and then determine whether or not our complex system has enough resources in order to do this. I really call out here too, the increased focus on outpatient settings. We know that we're driving more and more patients to those settings, which is great. It's convenient for them, but it also adds a different element of risk where you don't have the same level of infection prevention oversight as you traditionally do in the inpatient setting. So that appointment of the infection preventionist, right, really has to be done by that governing body. One of the things that I would also throw in the mix here is that if you're appointed by the governing body and you're executive, right, then also ask for a statement of authority. That statement of authority gives you the ability to immediately act when something is unsafe. We see this in the manufacturing community where if you're walking through the plant floor of a Toyota plant as an example, and you were like, wait a minute, that looks completely unsafe. That could kill somebody or that could harm somebody. Everyone in that building is empowered to stop the line. The same really needs to be true here. Everybody needs to be empowered to say, stop, let's get our management team down here, let's stop the procedure. But the infection preventionist has to have the ability with the support of the governing board and the executive suite to stop anything that is deemed unsafe. Maybe this is something as powerful as closing down the ORs because you had a breach in sterilization. These are things that are really, really important. The other piece to this too is the IP that's appointed maintaining their competency? If you maintain your competency by never going to a conference, by never reading a journal, by never really doing any professional education, is that really maintaining your competency? I think we would all argue absolutely not. And so there is responsibility for the governing body to make sure that person is up to date, right? That may be done through human resources as a delegate or through the executive suite, but we want to ensure that we're always matching up the resources with the needs. So from a survey perspective, right, they're trying to make sure that the policy and procedures match what the annual sort of risk assessment is showing, but there's also consistency in our practices, whether it's our inpatient care delivery versus our outpatient settings. And as healthcare continues to aggregate, especially as we look at the way the economy is right now, we're going to see more and more drive towards that outpatient setting, more urgent cares, more dental practices, more primary care clinics, and ambulatory surgery type organizations that are coming under our umbrella from a hospital perspective. And so we want to make sure there's consistency because the patients expect that, and certainly infections don't know boundaries. Another area that they've really drilled in on in this new interpretive guidance is the clean and sanitary environment, right? This topic is not new, but what they're really looking at is making sure that there's consistency in this approach. And one of the things they talk about is that it includes all hospital departments and off-site locations. As we look at more and more of the outsourcing model, particularly for environmental services, this can get a little dicey, right? Especially if you have outpatient, ambulatory centers, or you've got physician office buildings or things like that that may not be clean and disinfected by your direct team members. If you've got contracts with like the Airmarks, the Sodexos, the Morsons, those types of folks that might go in and do that, they're still part of your license, right? They're still part of your process management that you have to be responsible for. The other thing to consider too is there is a new ICRA 2.0 process that came out from the American Society for Healthcare Engineers just about 2 weeks ago. If you're not familiar with that, I encourage you to check that out. We've also done a grand rounds on that as well. But the repair and the renovation and the construction activities can not only just be stressful for the infection preventionists, but they can also be hugely problematic when they're not properly managed for the facility. And we certainly want to have the environment safe, especially where patients are cared for. But if we've got areas where there's construction and renovation taking place, we don't want those things to sort of, whiffed into the areas where patients are being cared for. One of the other areas to consider too is some of the different building systems that we have, like the air handling system. We're going to talk in just a second about the water management plan as well. But things like ice machines, right? What is our plan for maintaining these and ensuring the safety for all of the things that are used to care for our patients? And frankly, they're also used by our staff members as well. So they have directly called out the water management plan. This is something that is a pretty extensive topic, one that Ruth and I've talked about, even doing a sort of separate program on. We're also going to try to recruit an expert from CDC perhaps to do something with this as well for boot camp. But the water management program has to be in place, right? And so they have really broadened this beyond just Legionella and really look at other opportunistic pathogens in your building water systems. And they do defer you back to the new water management toolkit that CDC's had out there for just a few years. The web link is available there for you as well. You can also download the ASHRAE standards also, but all of the information from the standard is included in the CDC toolkit. And so if you're looking for a great starting place, go to the CDC web link there, and it will actually get you started with everything that you need. But again, we're looking to have a plan in place, a mitigation thing, is sort of follow up, and then what would we do if we had some type of issue there? So from a surveyor perspective, right, they're going to check and make sure that that risk assessment has been performed, that there's a plan in place, and also looking for how are you evaluating the efficacy of your testing protocols? What would be sort of your excursions, and then how would you mitigate those should you have those? So that corrective action plan, and again, that can be driven from your quality and performance improvement departments, would be good collaborators for that piece as well. So what about surveillance, right? Again, they talk very broadly about hospital-wide capacity, right? But it doesn't have to be that way all the time. right? And so we know that there may be mechanisms that we could sort of flip on or flip off. We know we may do whole house surveillance for certain things, and certainly for NHSN required items. But maybe we have an outbreak of a specific pathogen that we have to look more broadly for than we would do. What are our sampling capabilities, right? Do we have a relationship with both our internal lab as well as our external lab? And then how are we benchmarking ourselves against the NHSN data that we have? Now, part of our challenge, of course, with COVID has been that our NHSN data has not been really robust, because we've certainly had some changes from that perspective as well. So we really lost a lot of the validity, I think, in the last couple of years, because we haven't been able to accurately report. But the numbers that are coming out of CDC so far, looking at overall rates of HAIs, have really shown some pretty prominent increases during the pandemic. So certainly not terribly surprising there. So the next area that they explore is outbreak recognition and management. So first and foremost is, do we have a good process in place to recognize the outbreak in the first place, right? Because if we can't start there, then there's no way that we can actually contain the outbreak. And so it's really about detection, then recognition. How do we then put in place our mitigation plan to stop it so that it really impacts the minimal amount of patients? What precautions should we take? Is there going to be just-in-time training, for example? Do we have to go to some enhanced level of PPE? And then what are we going to do with our public health partners? That is a huge element that we've got to consider as well. So the surveyors are going to look at, right, do you have policy and procedures in place for your sanitary environment, with a focus on some of your core areas like surfaces and floors and your air inlets, your food service areas for sure. With the food service areas, they want to make sure the staff are ServSafe certified, which is available through the National Restaurant Association. If you're an IP and you've never been trained in food safety, I would strongly encourage you as an action item to take the NRA ServSafe program. To be able through the National Restaurant Association, it's not terribly expensive, but it will give you a great primer for food safety items, so that if you're ever involved in an outbreak in your facility, you've got that already under your belt and you can very, very quickly respond to some of those concerns. That second element is, once we identify we've got something going on, how do we work with public health? Right? We know that public health can bring to bear tremendous resources. They're excellent partners, but they're typically understaffed. And so we want to be very proactive in our approach, give them all the information that we can, and then make sure that we're good partners in that outbreak investigation. We don't want to hide from them, right? We want to be very proactive in that approach so that we can really work, hand in hand and actually get to the bottom of what may be going on. They can also open doors if we need to, have additional testing resources through like the State Public Health Lab or CDC or other entities. They think be great resources for us. And then lastly is that water management program. Do we have something in place to detect, to mitigate, and then to remediate if needed? So the overall infection prevention program, right, we know that we're required to have one. We know that it needs to be reflective of the scope of services that we offer. So that's going to be based on our risk assessment, but it also has to look at the total community picture. So that total community picture should ebb and flow pretty much every year. You may, take services away. You may be adding services. Your community may change. Your demographics may change. But at the end of the day, the expectation for safe care is not going anywhere. And so our practices, our evidence-based policies and procedures should pretty much remain the same, but we may need to make some small tweaks and adjustments in order to do that. And that's really where that sort of mechanism is there to be able to be a little bit more agile so that we can respond to those demands in the hospital environment. So how are they going to survey for this? Well, first and foremost is they're going to really say, do they have some type of program in place that's able to respond to this? Are they using information gathering? Are they using some type of critical assessment tool? What type of data are they collecting? How do they analyze that? Is it real time? Is it retrospective? Right. And then lastly is, are they looking at some type of active surveillance program that is going to allow us to intervene before more patients might be potentially harmed? Now, depending upon what type of services you offer, your average length of stay, that may or may not be true. But having something in place, especially with electronic data availability that's more real time, can capture some of this stuff before these patients might even get discharged. So what about stewardship for antibiotics? Well, this is becoming an even more heightened issue, as it should, because we know that antibiotics truly as a drug class have a community level impact. And so as we think about that, we want to be very cognizant when we're hitting prescribe that we realize all of the potential impacts that might be here. right? And so this is something that's going to be jointly led ideally by both an ID trained physician and preferably an ID trained pharmacist. Now, that's not always possible. We recognize that that's not a resource that is always available. You may have a consultant that may be available remotely, but having somebody who is going to lead it from a provider standpoint, and then somebody who's our true pharmacology expert working together is an amazing co-team lead there, right? And again, these individuals need to be appointed by the governing body based on their expertise, as well as their ability to influence change. Just like the IP needs to have the right personality to go out and influence change, the same is true here. But the most important element is not just the appointment of these people and their training, but really the support for medical staff services, right? And then the infrastructure that comes from our pharmacy colleagues so that we can have really good data to make good decisions. But at the end of the day, if the prescribers don't follow the recommendations and they don't use the data to more effectively guide their prescribing practices, we're sort of dead in the water here. Right? And so we want to make sure that we're thinking about that from a culture standpoint. So they don't, again, specify the number of people that have to be involved in the process. So that's really up to us, but they want to make sure the work's getting done. So quick rule of thumb is if you have goals and objectives and you're able to meet them, then you are getting the work done. And so you can check that box from a CMS perspective that you're meeting your objectives, you've used your risk assessment, you used your sort of community assessment. But if every single month you're checking the box of we're not getting any of this stuff done, then you know you have a resource gap or you have a time management gap or you have a combination of both. And so that's when you have to go back to your governing body and say, we're unable to complete these tasks and here's why, here's the resources that I need. Maybe it's an additional 0.5 FTE for data analysis. Maybe it's another full-time FTE. We don't know what it is, but your business case is going to drive that. And again, that's going to be based not only on the census that you have, but also the complexity of healthcare services that you offer. So what about qualifications for these folks? Well, just because you have training doesn't mean you're automatically qualified. Just because you have MD or PharmD after your name doesn't really mean you're the adequately qualified person. What we're really looking for is somebody who's taken some additional training. Maybe they've done a fellowship or residency or something like that in this particular area, or they're board certified in these areas. So that's why that recommendation of an ID trained physician and an ID trained pharmacist is the ideal, right? And so there are different programs. One that I would mention for those of you that are not prescribers, but or not pharmacists either, is that SHEA and IDSA both do have an excellent online program on antibiotic stewardship. There's also some programs available for free through the CDC. I'd encourage you to take them. It is a great resource to have. Even if you're not issuing the prescription, you're still part of the chain, right? And so the more people that are educated, involved, and really speaking up, the better we can be for our patients and the folks that we're trying to serve. So the way that we maintain that competency, again, they're calling for show me the money, right? How do I know that you're still competent? Just because you were trained 20 years ago doesn't mean that you maintain that competency. So professional conferences, board certification maintenance, they may be going to different meetings and presenting as an example. These are all quick and easy ways. And again, this can go back to that personnel file management to say, how do I ensure that the folks leading this team are going to be qualified continuously and not just sort of stagnant in their approach? So as we think about this in terms of us going for professional development, this is another thing to pull out, right? Use this in justification to go to conferences. Use this interpretive guidance when you say, I need to get this additional skill set or this additional certification, whatever it may be, so that you can actually get more support from your leadership. So from a survey perspective, right, they want to know that there was an appointment process, how they were appointed, that there's resourcing available, that you do have policy and procedures that are in place and people are not only following them, but you're looking to see if they are. And if they're not, you're identifying why, right? That's an important element of this. And if we're finding sort of gaps in our armor, then let's address them from a quality and performance improvement standpoint. There may be some great lessons that we can learn, but again, surveyors are not being as prescriptive as they used to be, which is helpful. Now, that does not mean that you're not going to still get a rogue surveyor, but it does give you a little bit more flexibility to show your amount of effort and what you're doing versus having to go down a very, very narrow pathway that might be a little bit more limited. One of the other elements too, just like we talked about before, is what standard are you following? There are many different standards, right? There's the Pharmacy Association has their own, and then certainly the Infectious Disease Society has standards. There's also great references and sort of resources available from the CDC. You've got sort of the core elements for antibiotic stewardship programs, not only for acute care, but also for ambulatory as well as long-term care that you can use, because it's not just about the expertise, it's not just about the tracking, but it's really about how do we convince people to be better prescribers so that our patients are getting that benefit. And frankly, we have these wonderful drugs in our arsenal to use for the really nasty bugs that we need. And then what about leadership, right? This is where the hospital's governing board becomes involved. They've got to be involved. They've got to be educated. They need to be knowledgeable, which means we should be presenting to the board, right? A lot of people tell me all the time, well, I don't ever present to the board. Well, ask for the opportunity, right? It's part of the standards that we should be rolling this information up to the governing board so that they're seeing the progress. Just like they see quality reports, they certainly are getting presentations from the chief quality officer. They should be getting infection prevention reports. Now, this may be done through the quality report. That's certainly fine as well. But you want to ensure that all of the different elements, antibiotic stewardship, infection prevention, our culture piece, right? Where are we with our rates? All of that is part of this process so that we're measuring success, we're learning from our failures, and we're also moving towards the future. So from that standpoint, from a surveyor perspective, right, all they're looking for is, are you following what you set out to do? And then also, do your meeting minutes for your actual committees reflect that? This is where the meeting minutes come in handy. If you are really doing a good job and you're documenting that and you're showing progress, that's a good thing. But if you're not taking good meeting minutes, or it looks like there's really stagnation taking place, this can be particularly problematic. And so surveyors don't want to see that. And so always try to move the needle forward, even if it's slow and steady. That's better than retrogressing or not making any movement at all. They also want to make sure that folks are involved in the process, that it's a coordinated, integrated approach. So this can't be done in a vacuum with the IP. It can't be done with just pharmacy. It can't just be done with quality. It has to be everybody, right? Because we know that this is a complex problem and a complex system with many high acuity patients. And so our role as infection preventionists is to really drive the bus, but we have to have everybody else on the bus with us, right? And sometimes we're going to allow somebody else to drive the bus too. And that's completely fine. It's almost like switching shifts when you get tired. But leadership has to always be on our bus, and you need to be in that front seat so that as we see something in the road, we put them out, they go move it out of the way, and then we shut the door and we keep going, right? It's all about getting that engagement there. And the national standards are really not going to be driven by any particular one entity. I mentioned CDC earlier because that's the most logical place to go, but you're going to find other specialty standards like ARN, or you may found like the National Healthcare Safety Network may have specific things that you have to follow, right? But look at what you're trying to accomplish. If it's a specialty area, look at CDC's guidance first, and then look at that specialty area in parallel. But we need to be flexible in our approach. We may be using data analysis and data mining tools. Those tools are great, but if we don't use the data and we don't act on the data, they're not so helpful. And then lastly is, are we actually measuring what's taking place at the bedside? Are the things that we're trying to do actually working? Are they actually taking place? Or is there this gap between what's reality and what's perception? You see this all the time where people will report stuff in a committee, and then you'll have a staff member that's at the front line saying, but that's not what's actually happening. And no one on the committee realized that because they're never at the bedside, right? And so that's going to be sort of a gap. So again, from a survey perspective, they want to look at what was your rationale for your national standard, right? So are you using CDC? Great, that's fine. What was your rationale behind that? It's the national guideline from our public health authorities. Okay, you're looking at the perioperative environment. Why did you choose ARN? Well, that's the National Perioperative Association. Right, so you can very easily justify that, but make sure your policy and procedures are well cited. I hate seeing policies and procedures that are cited back to textbooks like Lippincott. I see a lot. That is certainly helpful from a procedure standpoint for certain things, but it is definitely not helpful from an evidence-based standpoint because it changes so rapidly. And then our surveillance documentation, right? We may be using electronic surveillance or paper or a combination thereof. But most people are moving towards electronic. And so we want to ensure that not only are we collecting that information in a systematic fashion, but then we have a way to get that information to the people that matter, the folks that are making the decisions at the front line, the folks that are leading the units, that are caring for the patients, versus having it sit and then we're reporting it out 30 days later when the patient is long gone and we have zero ability to impact that person. And the quality team is going to be a good partner in this because they're ultimately responsible for looking at our quality improvement and our performance improvement efforts. But they also have a big stick,
right? Because they're really looking at those core measures. And so if we're looking at something that is not a typical problem and suddenly it is, they may be able to help us have that sort of red flag alert and say, wait a minute, on 3 North, we're having this issue over here. We might need to go try to address that. And so their systems are pretty robust. And when we collaborate effectively, right, we can do many, many powerful things, and we can be proactive in our approach, which is always going to be better. And the last little area is about competency-based training. I talk about this all the time. Have you ever worked with somebody who was really well educated, but very incompetent? I can think of many people I've worked with in my career. You can all probably think of folks that fit that exact same bucket. But competency role-specific training is really where the money's at, because we can get more results, we can get better return on investment, and we can have a higher degree of confidence that the folks that are doing the work in that particular role have the necessary requisite experience in order to do that. How I train a bedside nurse is going to be extremely different than how I train somebody who's a hospitalist, or how I train somebody who is a clinical pharmacist, right? Very, very different people. They all are part of the care team, but I need to think about the competency and the role-specific training that they have. So they're looking for policy and procedures on that. They want to make sure that that is part of our infection prevention program, and that the competency is driven by role, and that we are looking at staff records to ensure that they are completing that competency. Again, this may be something that's done in collaboration with either the unit managers and human resources as well, and it can also be done electronically for sure. And from an auditing perspective, they want to make sure we're looking, right? Are we actually going back to double check that what we think is happening is truly happening? Are we showing adherence to what we say is taking place at the bedside? Or is that just all minutia that we think is taking place, but it's all hogwash when we actually get out onto the units? And so verifying that information is really what the surveyors are looking for. And again, using auditing tools, documenting that at a specific cadence, maybe monthly, is going to be a really good start from that perspective. Now, we recognize that every hospital is going to be different. The patients are going to be different. The services they offer are going to be different. How they deliver the services may be slightly different. The geographies, right? The patient complexities, all that kind of stuff. But the same expectation of safe care is there regardless. Whether you're in a hospital, long-term care, it doesn't matter. And what they're looking for here is some good, reasonable effort, that our efforts are integrated, right? That we're not sort of operating in silos, that we're not poorly resourced. Now, this doesn't mean that the CEO has to give us as many IPs as we want. That's not what this means. But it does give us a little bit more of a teethy approach, if you will, to say, I can bite into this and I can take this information back to leadership to say, I need additional resources and here's why, right? And again, they're going to be looking at that to say, is the population served matched by the infection prevention program that we have in place, both the IPC program, but also the stewardship program as well. And then as we train hospital staff, we need to make sure that that's done appropriately, right? And so that we can really ensure that the role that they're performing, they've got the training for it, and we're validating that. This also includes contractors as well. And they're going to look for that information in their documentation. So it's not just our employees, but it also includes the folks that we are directly employing, as well as those that might be coming in as a third-party service. So with that, I'll stop and see what questions you have. And I know it's a ton of content. We will make the slides available as well. And like I said, I'll also share the full CMS interpretive guidance in case you are looking for something to read on a Friday night with a glass of wine so that you can go to sleep. But Ruth, I'll turn it back over to you to see what questions there might be.
Thanks very much. I think this content was great. I think that the two big issues, one, the water management plan that we know now is important because of the flooding, and I put information in there that the Andrea Flincham and her office sent out a document with some really important points in water management that are relevant for all healthcare facilities. So if you did not receive that or you can't find it, email me and then I'll make sure to forward that to you. Secondly, you talked about antimicrobial stewardship, and with the information that we've been provided about the increasing numbers of HAIs and what our response has been, trying to juggle that with pandemic response. The whole notion of reducing resistance becomes key. And I also put information about what the training center is doing and the project that's being led by Dr. Ashley Wild for the state of Kentucky as part of the training center activities So make sure that if you are unaware of any engagement so far at your facility, please send me an email and I can share that with Dr. Wild. So she will have that information and can either reach out to you directly, or if she already has a contact at your facility, to reach out around what all of the activities are underway regarding stewardship. So I don't see any questions. I think everybody's trying to digest. That was a great overview and a lot of information. Dr. Ramirez, do you have any questions or comments? I know you are, a lover of stewardship activities. So I know this made your heart sing, right, to see this.
Well, I think that what you just mentioned, Ruth, that since stewardship now is necessary at every level, and I think Hudson mentioned that not everybody's going to have an ID pharmacy or an ID physician. Probably this will require collaboration, and I think that the training program is ready to collaborate. It was already alluded that several times that because of the COVID, during COVID, has been an increase in healthcare associated infections, because again, large number of patients, the isolation, these patients were immunocompromised and over antibiotic use in COVID. And Hudson, you mentioned that outbreaks recognition and management is critical, and we need to have a good surveillance program. Sometimes I've been in discussions. Sometimes you're in an institution that your number of nosocomial infections or healthcare infections decreased significantly. And then on and off, you get one case here and there. And then the question is sometimes, then what is an outbreak? When do I say that I have an outbreak? Because on one hand, if I don't call it an outbreak, by next month, things can be out of hand. On the other hand, if every time they have one case of this or that, I call it an outbreak, I'm going to be doing outbreak investigations constantly. And really, even though we are supposed to be doing an outbreak investigation, nobody had the extra time to do. Then to call it that we have an outbreak is something that have implications. And at this moment, what would be your of course, I'm sure there's no right or wrong, but what would be your consideration to say, yes, there's an outbreak, let's call the troops and let's get around and let's try to do the investigation?
Yeah, I mean, I would agree with you. I'm not sure there's a right or wrong answer, but I mean, my philosophy has always been know your baseline. So if my baseline is 0 and I know that, a couple times throughout the year, I get 1 or 2 of these and I never see spread right within my facility, then I'm much less likely to have an issue. Especially when I'm dealing with certain populations. Let me just give you a population that always pops up with certain things like this, which is prisoners. If you're a facility that treats prisoners, you're likely to get some MDROs that are going to come in for sure, because they're going to come in from the facility, or, even STIs. And so maybe you have, none of those in your facility throughout the year. And then suddenly you have, 1 or 2 a month when you see a specific subset of the population. If you're able to maintain those with good isolation precautions and not have any spread, then I think it's less likely that you have to go down the full path of an outbreak investigation. But certainly if it's something that's publicly reportable or there's a high risk, I think to your point, then you would have to do that. But if your baseline is 0 and you always see this and it's seasonal, and you've never had an issue, I think there's pretty good justification to not overreact either. So I think we're sort of finding that happy medium spot.
I think too, as you mentioned, public health, that it's always good, have that relationship with whoever your regional EPI is or your regional IP, and know the infrastructure that's present in your state, because you can always call them to say, I saw this, and I'm not sure it's an issue at this point beyond what I would routinely do. But as we've learned with some outbreaks, I may see one, someone else may see one, someone else may see one, and somehow all those ones are somehow related. So, we look at not only what happens locally, but we're looking at, what the potential is for a public health issue. So thinking locally, but at the same time thinking, more a little broadly is always great. And I think I've never found anybody from public health who would say, I wish you didn't call me. That I think they would rather know than for them to say, gee, I wish you'd called me. I see Andrea's picture lit up right there, and she may want to comment on that as well.
Definitely. No, we have, to my knowledge, no one in my program has ever said, I wish you hadn't called me. But, by regulation, if you see two cases of something that are epi-linked, like you talked about, Ruth, but like person, place, or time, then you certainly want to look at that and you can call us for advice. But if you see a pathogen that you've never seen before, so if you've never had Candida auris in your building and now all of a sudden you see a case, then that's important and you need to contact us and we would consider that an outbreak. So I appreciate the public health prompts there.
Well, I think, that this is actually right. As we understand the IP workforce, that we have so many new people, thank goodness, that are coming into the profession. And it's a reminder that, anything that you don't know, don't be afraid to say, I don't know, or I've never seen this, because literally all of us have been there at some point. That we would rather somebody come forward and say, I have a question. And, some of these pesky organisms, they keep having their name changed. So I knew them, as a former pathogen. Now I don't recognize their name. So this is one of those, that we're in a field where, there's, nobody should get ganged on and nobody gets finger pointed or whatever. This is one of those things where truly, united we stand sort of thing. We work together and share information together. So thank you. Thanks for that question, Dr. Ramirez. I think you set up the whole discussion about public health importance and what our role is and how we relate very well.
It's also, Ruth, you brought a point that we discussed here with microbiology. Now with new techniques that they can keep identifying the different species. Sometimes we call it Pseudomonas, and it's no longer Pseudomonas aeruginosa. Now we have a different name, but it happened to be the same Pseudomonas that we used to have. And the question is, where do you draw the line? But I think it's important to discuss. Whenever you have a name that you don't recognize, it's important to check with someone to see, okay, what is the meaning of this new name?
I think this is a great topic. Clearly, we could stay all day, I know, and I appreciate everybody's time very much. We will continue to clean the recording and tighten it up and make it available on the YouTube channel so you can go back, listen, or since this is something new that's coming into our facilities with these updated interpretive guidance, it may be something that you want to pull your team together, go through this presentation again, identify where you are with all of these different elements, and then using the documents that Hudson will share, and as well as some of the documents that Andrea put together and sent out specifically about water management. This is all very timely. So go back to that site, and hopefully that will be an important addition in how you educate and work with your personnel. So thank you again. We will next week, interestingly, we will be talking about viral illness and viral infections and antimicrobial stewardship. So still along the line of, our current reality with viral illness and our current areas of interest in antimicrobial stewardship. So we'll have one of our pharmacists, Dr. Sarah Moore, will be addressing that next Wednesday. So thank you all very much and have a great rest of the week, and we'll see you next Wednesday.